Welcome, it's Dr. Jack, and I'm here with Dr. Stephen Richeimer. Dr. Richeimer is a psychiatrist and a pain specialist with a specialty in anesthesiology. So thank you so much. As I was telling you, I really enjoy your lectures because you really give us the big picture of pain in a way that is very, I think, relevant to us in the mental health field. So I think it would be really helpful, and I would really appreciate if you could give us, like, what do you think are the main messages that you would want us to know, like kind of a billboard for that every mental health clinician could see. What would it be that you would like to share with us?
Okay, I think there's a few things.
Okay.
One is that
you can have as many billboards as you like.
I think I'm going to start off with the idea that treating pain is a multidisciplinary exercise.
Okay.
And we really do need teams of people to be working together to help patients who have chronic pain. Mm-hmm. And the mental health clinician is a crucial part of that team. And so part of the message is that for the non-mental health clinicians, it's to be sure to include the mental health clinicians. And for the mental health clinicians is be aware of your expertise and how useful it is in this field. Be interested and reach out to your local pain centers because they need you. So I think having a multidisciplinary team is sort of maybe my first and maybe key point.
I think that's so important because I think too often, as a psychiatrist, a patient will just come in and saying, like, I have chronic pain, I'm on this SSRI, I'm on a benzodiazepine, and I'm on this opioid pain reliever, and somehow I need a refill. And too often, we feel somehow pressured or even intimidated perhaps to start prescribing without really feeling really good about it, because it could certainly be outside of our wheelhouse, something that we're really not competently trained to do. And I think just hearing you say that, it's like, yes, we're not alone. We're part of that team, and we probably shouldn't be doing this alone, and especially in this kind of like pressured, like, now or never kind of approach that sometimes patients like to, in a way, convey to us.
Well, that was a good lead into my second point.
Oh, great. All right, good. We didn't practice that, by the way.
So the second point is get educated.
Yes.
And that is, because the state of education in pain amongst all clinical fields is terrible. Mm-hmm. In medicine, the average medical school provides 9 hours at a medical school. And pain is the number one complaint that people go to their doctors with. And they get 9 hours.
Yes.
And
that, by the way, includes things like headache and migraines, which are so common. We're not talking about some chronic, orthopedic
thing, right.
Kind of pain, right?
Absolutely. And once you leave medicine and you start talking about, pharmacists and dentists and physical therapists and psychologists, etc., they get even less. Mm-hmm. So message number 2 would be seek out education. I mentioned that USC is trying to fill that gap by offering some online education in the area, but there's other ways to get educated, and people should really seek out education. So is that like a course you got to pay for, or is it free? Yeah, no. It's a regular USC tuition, unfortunately.
Oh, okay.
Where it's part-time for a year online, either to get a certificate, or part-time online for 3 years to get a master's degree. Mm-hmm, mm-hmm. And people are welcome to reach out to me if they're interested in that. But education clearly needs to be improved on the individual level, and the nation as a whole has to be thinking about how we do this.
Yes. Which is pretty stunning, back in around the turn of the century, it was like, pain is the fifth vital sign, right? Okay, granted, okay, it's a problem, but then no follow-up education. So it's basically, it unleashed, tens of thousands, hundreds of thousands of clinicians to start prescribing without any kind of further training. And it was, the level of training was really, from a baseline that was really pretty abysmal, as you say, 9 hours. And as a psychiatrist, it's not like I had, I don't know if any further training about pain in my residency.
Right. I think that's true in most residencies.
Yeah. So, so we're not going to be able to convey half a year's worth of a course, certificate course, but what would you say are like maybe one or two of the main things that you would just really like to convey to clinicians on, maybe like cautions, like mistakes you've seen made that you just would like to caution us against ourselves making?
I don't know that there's single things, but I'll mention that I think opioids have been overused largely because clinicians don't feel like they have any other alternatives.
Okay.
And there are alternatives out there, both pharmacologically and non-pharmacological, and team approaches. And if clinicians take the time to get educated about some of the approaches to pain other than opioids, I think that would make a big difference. And it's not just psychiatrists, surgeons. Surgeons, yes. I can't tell you the number of times that somebody has a relatively small surgery and walks away, comes home with a bottle of 60 tablets of Vicodin. At the most, they should need 3, 4, or 5. They don't need 60 tablets. So it's a uneducated response, and it's also not thinking about the alternatives that are available.
And it reminds me of the point that you made that I really like, that pain does not equal suffering. That whatever level of pain could be associated with just very little suffering. Because of the context, perhaps, or sometimes because of the genetics. People somehow may be less having a lesser experiential experience of it. There's so many different factors, and yet another person may have just a huge amount of suffering based on that. So I think this is where really doing a thorough psychological assessment is really crucial, because it's not, is there a physical condition there? Usually yes, but is there a lot more going on? Yes, and sometimes that other thing is the majority of what's going on. The actual injury might be this big, but the suffering may be this big. Why? Why is that happening? But you have to ask those questions. You have to know to ask those questions.
Absolutely. And one of the mistakes that clinicians make when they refer to a mental health professional, and sometimes it's even made by the mental health professional, is creating the impression in the patient that this referral means we think that the pain is in your head.
Right. And so right away they're kind of like, it kind of breaches the trust even between them and their initial clinician, let alone with the mental health clinician that they're being referred to.
Right.
That's a great point.
Absolutely.
So it's not
it doesn't
either
have to
or,
be that
right?
at all.
It's usually both, right? The physical and the psychological aspects.
So we try very hard to educate our patients that the mental health techniques, the psychotherapeutic techniques, are a tool for treating physical pain. So they go in there with that expectation. Now, it may come out during the psychotherapy, I would say it usually comes out, as you said, that there's factors that make the physical worse, that increase the suffering, and that often there's things that can be done to help with that too.
Well, again, thank you so much. I always appreciate your lectures, and I hope you'll be joining us in the future.
Thank you. My pleasure.
Thank you.
My pleasure.